Hello friends, I'm Dr. Santosh Abraham, Specialist Registrar in Endocrinology and Diabetes at Scarborough General Hospital, and today I will present genetic factors in type 2 diabetes mellitus. I won't go into details too much because it's beyond the scope of our exam, but for a better understanding of various monogenic and polygenic forms of diabetes, and for the understanding of inherited diabetes, it is good to have a basic knowledge about the genetic factors. What are the features of type 2 diabetes mellitus? There are three cardinal abnormalities. One is resistance to the action of insulin in peripheral tissues. Second is the defective insulin secretion, especially in response to a glucose stimulus. And third is the increased glucose production by the liver, increased hepatic glucose production, or HGP, and which leads to hyperglycemia in the fasting stage. Also, people with type 2 diabetes will have hypergluconemia, alterations in incretin hormone secretion or action, increased lipolysis, increased renal tubular reabsorption, and even abnormalities in the CNS. Pathophysiology. So in type 2 diabetes mellitus, it is the inability of the pancreatic beta cells to adapt to the reductions in insulin sensitivity, which will precipitate the onset of type 2 diabetes. The earliest detectable abnormality is insulin resistance. Indeed, the resistance may precede diabetes by many years. Puberty, pregnancy, sedentary lifestyle, and overeating, which leads to weight gain, could all place an increased burden on the beta cells. An underlying genetic predisposition appears to be a factor, even though the proof is not that convincing. Polygenic or monogenic. In fact, both of these are implicated in type 2 diabetes mellitus. The common forms of genetic factors are polygenic, and these are caused by the interaction between genes and environment, and also epigenetic factors. The monogenic forms are rare, but it is important to recognize the monogenic forms because they have given us more understanding about the physiology of diabetes, and if identified early, we could start appropriate therapy. I'll discuss about the monogenic forms of diabetes associated with insulin resistance. First, the monogenic forms of diabetes are usually diagnosed in younger patients, and if it is mild, the diagnosis may be missed until later. So the monogenic forms could be divided into two, in which the mechanism of the first one is caused by a defect in insulin secretion, which will not be discussed here, and the second mechanism is due to the defective responses to insulin or insulin resistance, which will be discussed here. Mutations in the insulin receptor are implicated in the monogenic form of diabetes. There are three clinical syndromes which are of interest. So here the insulin receptor gene is mutated. The first one is type A insulin resistance, which is characterized by insulin resistance, acanthosis nigricans, and hyperandrogenism. It is diagnosed when patients become adolescents or as young adults, as you see acanthosis nigricans or signs of hyperandrogenism. Donahue syndrome, however, presents very early with severe IUGR and abnormal facies, and death occurs in first 2 years of life. However, these patients may have episodes of hypoglycemia in spite of their high insulin resistance. The third one is Ratson-Manhal syndrome, and it is associated with short stature, protuberant abdomen, and abnormalities of teeth and nails. Coming to the type A insulin resistance, which is most important of monogenic forms, here the majority of mutations are associated with the intracellular tyrosine kinase dominase, whereas in the other two forms the extracellular domain is affected, and hence there is an impairment in the ligand binding. Another form of monogenic inheritance is seen in lipodystrophic diabetes, which I will not talk in depth because it's a very vast topic. So lipodystrophic diabetes syndromes could be either genetic or acquired, and these are syndromes of severe insulin resistance associated with lipoatrophy and lipodystrophy. There will be paucity of fat, insulin resistance, and hypertriglyceridemia. There are two kinds: generalized lipodystrophies and partial lipodystrophies, and mutations in each categories have been identified. I'm not going to talk about the mutations because there are a lot of mutations and it's not worth talking about all of them here. But one of the important mutation happens in lamin A gene called the LMNA. It could result in a phase pairing familial partial lipodystrophy known as Denigan syndrome, or as a different mutation in the same gene could also result in mandibuloacral dysplasia syndrome. This is just for the sake of the exam purpose that I'm telling you this. A feature of the generalized lipodystrophies is that they are characterized by leptin deficiency, and even leptin replacement have improved the glycemic control. Now let's discuss about the genetics of polygenic forms. So I will go to the various genes implied in the polygenic forms. With that, this topic will be over. The most important gene is transcription factor 7 like 2, that is otherwise called TCFL72 gene. So a microsatellite in one of the introns of this gene is associated with type 2 diabetes mellitus, and specific polymorphisms in this gene increase the risk of progression from impaired glucose tolerance to type 2 diabetes mellitus. This also is associated with reduction of glucose-induced insulin secretion. It is believed that it acts through the regulation of pro-glucagon gene expression and thus influencing the WNT signaling pathway. The various common variants that determine the diabetes risk, those at the TCF7L2 locus have the greatest impact. That is the importance of this gene in the polygenic form of T2DM. Another gene, this is of historical importance because this was the first gene to be studied. So it is called the IRS1 or insulin receptor substrate 1 gene. So a specific polymorphism in glycine 972 arginine in the IRS1 was described. So it results in impaired insulin stimulated phosphatidylinositol 3 kinase signaling, but it appears to have only a minor role in the overall type 2 diabetes mellitus risk. Other genes are KCNJ11 and ABCC8. In the beta cell, there is a potassium activated ATP channel. So it is composed of two subunits, KIR 6.2 and SUR1. KIR 6.2 is the pore-forming component of this channel, whereas SUR1 is the sulfonylurea receptor. SUR1 regulates the opening of this channel. Once this channel opens, potassium moves out of from the beta cell, and it causes insulin secretion. So mutation in these genes are the most common cause of neonatal diabetes. The KIR 6.2, or otherwise also known as KCNJ11, and the SUR1. Out of this, the KCNJ11 is the most important. And identification of these patients is important because they can be treated by this form of neonatal diabetes can be treated by sulfonylureas rather than insulin. That is the mutations associated with KIR 6.2. Polymorphisms in these genes, like those in this case KCNJ11, could also lead on to development of type 2 diabetes mellitus in older patients also. And those patients who have the polymorphisms in KCNJ11 are more responsive, are more sensitive, or more will respond more to sulfonylurea treatment. The PPAR gamma gene is an important regulator of lipid and glucose homeostasis and cellular differentiation. It is most abundantly expressed in adipose tissue, but also present in muscle cell as well as pancreatic beta cell. When this gene is affected, there is changes in muscle fatty acid oxidation. So individuals who are homozygous for the PRO12 allele in the PPAR gene are more insulin resistant, and they have a 1.25-fold increased risk of diabetes. Another polymorphism is C161-T, which is linked to the insulin resistance in Hispanics. Loss of function mutations in the PPAR causes familial partial lipodystrophy type 3, FPLD3, and it shows dramatic improvement when treated with thiazolidinone PPAR alpha agonists like pioglitazones. You already know the mechanism of pioglitazone, so the HNL4 alpha gene, it was first discovered MODY gene, and it causes abnormalities in insulin secretion. HNF4 alpha is also active in liver. It is upregulated by an alternative promoter from the pancreas. So when you have changes in the alleles of HNF4 alpha gene, it will result in increased hepatic glucose production, but the insulin secretion is not affected. So there is a liver specific importance for this gene. That is, these polymorphisms mainly affect the hepatic glucose production. Another genetic variation, the liver specific promoter, is associated with the increased risk of T2DM. So HNF4 alpha, which is important for the gluconeogenesis, causes increased, if there are mutations, it causes increased hepatic glucose production, and genetic variations in the liver specific promoter of the HNF4 alpha is associated with increased risk of type 2 diabetes mellitus. Finally, the Kruppel-like factor 14 or KLF14, it is a maternally imprinted transcription factor. So non-coding polymorphisms are associated with increased fasting insulin, waist to hip ratio, and type 2 diabetes mellitus. The importance of this gene is that the variants of this gene can cause a redistribution of fat from the gynoid to visceral lipos and increasing adipocyte tissue. So you already know if there is redistribution of fat to the visceral lipos, that further increases the risk for metabolic syndrome. And it's important to know that the effects only occur in KLF14 when the KLF polymorphism is inherited from mother to daughter. So the effects only occur when it is inherited from mother to daughter. Thanks for watching this presentation.